We are going to talk about very interesting topics as part of the Advanced Pediatric Endocrinology Symposium. This is being organized under the banner of MedEClasses, Growth Society and Regency Hormone with support from Novo Nordisk. So we started off with pediatric endocrine awareness using workshops. And around 2011, we started the practical pediatric endocrine course. Then we conducted workshops across the country. We had a workshop in Patna also, I think 10 years ago. Then we had got PPC across the country. In Jaipur, we conducted. Then we realized that just doing workshop, it will require a huge amount of time and other factors. So we started on more of awareness programs on social media and YouTube channels. Then we started our on-site fellowship, that is 2017. And then we started the online program because that will give more access to people across the country. And now we have the mobile application, we have got the online fellowship programs, the other factors which are available in that regards. So over the last 10 years, we actually, when there was no COVID, we used to have every month one program here and there. And we had got huge number of practical courses, workshop across the country. But now, good or bad or whatever, we've got more of online activities which are there. And this time we have a hybrid program. So the first Advanced Pediatric Endocrinology Symposium happened in 2017. I think Dr. Sanjay and Dr. Pradeep were both there in that program. Dr. Amit was also there in that program. And Dr. Hemchand, who is part of this program, also was part of that program at that time. 2 years back, we had another big program with our on-site course, which was in 2019. Again, many of our friends were there, Dr. Pragya and a lot of other friends. Dr. Pratik was also there at that time. Then last year, we did it more in an online mode, and today it's a hybrid mode. So all of you can access our YouTube channel, which now has got a huge number of videos on nearly every topic of pediatric endocrinology. You can access them from there. You can go to our website, which provides a lot of information and courses which are available, including fellowship programs, diploma programs for postgraduates. And we have got 3 specific exclusive grand rounds which happen on a complimentary basis. Every month we have one for advanced in a fellow or a pediatric endocrinology perspective, one for postgraduates. And recently we have started a postgraduate lecture series for postgraduates covering the basic topics in that regards. You can access our publication and our mobile application. We are happy to announce that it is the most downloaded endocrinology app in the whole world. It has already resulted in 3 publications, and there are many other publications which are on pipeline. So this is something which is becoming, and we are going to enhance it very soon dramatically, and we'll get many more interpretations coming out of that. Who is to set up a way in which we can use technology to link different clinics together and to use technology to provide state-of-the-art guidance in terms of immediate care, management, research, and all those factors. But most important tool is what we call PI, which will be a personalized, intelligent, state-of-the-art EMR. So what it will do is that based upon the basic inputs that the doctors will give, it will use AI, multiple factors, and then try to come out with the likely diagnosis, investigations. A lot of things will come up immediately. Diet charts will come up immediately. So how it will work is that if you put a particular complaint, your field will come up like short stature. You will have some questions on history and examination. Immediately you can assess bone age. Immediately you can assess puberty. Once you do that and put analyze button, you will get a summary like this. A lot of app outputs will now directly come out immediately on the press of the button. The bone age will come like a proper report. So you will, which sites you have selected, what was the basis and what was the bone age was there will come immediately. And very importantly, based upon the weight, the BMI, the diet preference, the disease, we will make a 7-day diet chart. Again, a major challenge which is happening with regards to the pediatric population and adolescent population and what to do in type 2, what will be the appropriate therapy, how do we move forward. So Dr. Pratik will talk about all that and more in that regard. So over to you, Dr. Pratik, for the discussion. Dr. Pratik is a consultant at Regency Center for Diabetes, Endocrinology and Research. So Dr. Pratik, you take over from there. Yeah.
Thank you, sir. So since we've had such an exhaustive and such a fine discussion about type 1 diabetes, the question now arrives, what about type 2 diabetes in children and adolescents? Yes, it is happening, even though rare, but it is significant. And why it is significant, we'll have a small discussion and mostly focus on the management of type 2 diabetes in children. So beginning with, we had this 16-year-old girl with obesity. The fasting was 146 and after 2 hours was 224. HbA1c was 8.3. Ketones were 0.8. BMI was 32 and there was acanthosis. And there was a positive family history. Now, those hopefully who are aware will know that there is a chance of a type 2 component in children as well. So we should keep that in mind. This was diagnosed as type 2 diabetes. Now we'll be discussing about the various management modalities. And this child was started on metformin as the protocol goes. Coming to a second child who's 18-year-old, had obesity. The fasting was 188 and after 2 hours it was 340. Now here it is different from the previous child. The HbA1c was slightly higher at 10 and there was mild ketosis at 1.2. Here too, there was BMI 34 and acanthosis was present. C-peptide was 3.4, suggestive of a good C-peptide reserve, insulin reserve, and GAD65 was negative. Again, we'll discuss it, but these case scenarios, let's just keep in mind how various cases can present to us. So today's, of course, this child was started on glargine, and we looked at the response to metformin. So today's discussion will begin the various contents of the discussion. I will talk about the introduction, what is the burden of type 2 diabetes on the population, how we diagnose these patients, what is the management, and I'll continue these case scenarios and what happened to these children. So what is the burden of type 2 on our population? The global prevalence of type 2, of course, requires no introduction. It is about 8% and more than 90% is type 2 in adults. But there is a rising incidence of type 2 in children observed worldwide. And even Indian data, those sparse, shows that around 12% prevalence is there. Now, this is a very important point. Compared to adults, there is higher, whatever studies have been done, it shows that there is higher prevalence of family history, higher prevalence of diastolic hypertension. I am comparing type 2 adolescents with type 2 in adults. So there's a higher prevalence of diastolic hypertension, worse glycemic control, shorter time to insulin initiation. They develop adverse CVS risk profiles much faster and much sooner. And there's a risk of even cognitive decline. So if we compare type 1, type 2 in adolescents and type 2 in adults, the adolescent type 2 is at a much higher risk of complications than either of the two. So now how do we compare it with type 1 diabetes? There is significantly higher rate of microalbuminuria and rapid progression to microalbuminuria in comparison to type 1 diabetes. There's a 3 times higher prevalence of neuropathy. And retinopathy also has higher prevalence. So please be aware, any type 2 patient comes to us is a sort of at least OPD emergency. We should take everything in account and counsel the patient very slowly and carefully. So this table was given in an article given in Lancet. I would like you to focus on the role over here, the last point. Look at the rapid progression of insulin. By almost 50% will progress to insulin by 2 to 5 years in the second column as compared to type 2 diabetes and type 1 diabetes, just indicating how severe this issue can be. Of course, the various other complications, dyslipidemia, NAFLD, etc., can also be much worse in these children. So coming to the classification of diabetes, how do we classify, and whenever we have diabetes, how do we know it is type 2? So this is a very good algorithm. We look at the onset. If it is before 6 months, consider neonatal. If it is after 6 months, look whether DKA was present or not. If DKA was present, of course, that time we have to give insulin irrespective of whatever diabetes it is. Once it has settled down, you look at the insulin requirement. If there is an insulin requirement for a prolonged time, you omit your honeymoon phase, etc., everything 1 year, 2 years. If there's prolonged insulin requirement, it is type 1 diabetes. If there is very minimal insulin requirement, look at the antibody status. If it is positive, it is type 1. If it is negative, look for a MODY panel. Now, if there was no DKA at presentation, this is a slightly confusing bit, and many patients will come like this. Look at the GAD antibodies. If it is positive, type 1 diabetes. If it is not, if obesity is there, consider type 2 diabetes. If no obesity, no antibodies, no DKA, consider MODY. So the diagnosis of diabetes, all the associations, ADA, ISPAD, etc., they accept and they acknowledge the difficulty of diagnosing type 2 diabetes in adolescents, and it may be a gray area if the presentation is as such. So the diagnosis of diabetes is done by the basic whatever guidelines are there. That is fasting more than 126, postprandial more than 200, with symptoms, A1C more than 6.5. This is for diagnosing diabetes. Now, what ISPAD says about classification is how do we screen? Now, ISPAD also focuses on screening of children for diabetes. So what they say is, who do you screen? Basically, all children after the onset of puberty or after 10 years of age who have the following risk factors. That is obese, history of IUGR, first degree family history of type 2 diabetes, maternal history of GDM, high risk ethnicity, PCOS. Now, one very important thing is that we are, as Indians, a part of the high risk ethnicity. So in a nutshell, all obese children, even overweight children, should be screened for at least the sugar, which makes it a very important point. One very important point over here is pre-pubertal children are highly unlikely to be type 2 diabetic. So if any pre-pubertal child, and in fact, we even had one in our OPD, comes with obesity and looking like diabetes, it is unlikely that that child will be type 2 diabetes. Look for a GAD body as soon as possible. What about autoantibody testing? What ISPAD is mentioning is in all pediatric patients with clinical diagnosis of diabetes because of the high frequency of antibody positive. But this is, not required in all children. Of course, a lean child with history of osmotic symptoms coming to, does not require any GAD antibody. We know it is type 1. You look at why autoantibody is important in those gray areas. And of course, if autoantibody is positive, but child is behaving like type 2, this child might progress to insulin much faster than you might expect. So that is very important. And we need to consider the presence of other autoimmune disorders in such children who are obese, might have acanthosis, but antibody positive. What I meant to focus on that is don't stress on the diagnosis as soon as the child is there. Look at the sugar levels and treat accordingly. Treat accordingly. If the child is in decay, we'll discuss that, but don't stress so much that you don't treat. That is the main point. Now, coming to the management, our goals of management is first glucose control. HbA1c 6.5 obviously make it the non-diabetic. Now, we practically know it is very difficult for HbA1c 6.5 to occur in any diabetic child, who of course is presenting at say 10 or 11. So these should be practical and pragmatic. So I would say look for a progressive decrease in HbA1c rather than telling them to achieve an HbA1c of 6.5 or 6.8. But of course, 7.5 can be considered in children who are not able to achieve such low HbA1cs or is there risk of hypoglycemias. Fasting less than 130. Look for complications at diagnosis. This is not type 1 where we can wait for a few years. This is type 2. So at diagnosis, we look for complications and consider them. Weight reduction, of course. Now, weight reduction is another important point. Look for reduction, at least achieve 0.5 to 1 kg per month and look for at least 10% reduction in the weight. Now, weight management goal around 7 to 10% loss. Look at the BMI SDS fall. Try to bring them lower than the overweight category. As I mentioned, 0.5 to 1, and adolescents, you can go even higher. This is one very important, at least some of these individuals, they start following fad diets, such as keto diet and various other diets. If it is feasible, which is not in most of the cases, do not follow it because it is not sustainable. You cannot keep eating some children. It is very difficult and they start rejecting food altogether. A yo-yo diet leads to, again, gaining weight. So normal Indian diet, just with slight modifications. Now, coming to the therapeutic options, what all options do we have? Of course, the first option being metformin. Second option being sulfonylureas, thiazolidinediones, GLP-1 receptor analogues by the same category, DPP-4 inhibitors, glucosidase inhibitors, SGLT2 inhibitors, and finally insulin. Now, our age-old and most trustworthy metformin. Of course, we know it acts by MAP kinase. So there's action on the liver, muscle, fat. It reduces glycogen hepatic production and increases sensitivity to insulin. There is associated weight loss. So the protocol is 500 mg daily. Now, we have seen many patients who have been started on 2 gram directly, or rather 1 gram, and this has led to increased gastric problems, which you have seen. So always start slow and you can increase it progressively, leads to better compliance. Weekly increase it to 2000 mg. There may be side effects. You need to add multivitamins to it also. Avoid if there is any EGFR less than 60, any transaminitis, or any mitochondrial diabetes or acidosis. In cases of any CKD or liver disease, you can start on insulin. You can wean off the insulin by around 2 to 6 weeks, slowly wean it off, and then you can again restart till it comes down. Avoid metformin any sick day or when you're giving iodinated contrast or any surgical procedures. Now, this trial, the Today trial, was a very important trial. It compared children with type 2 diabetes, and what they saw children with only metformin with lifestyle, and a pioglitazone or rosiglitazone, and they saw metformin with lifestyle gave a very good response. Now, pioglitazone or these glitazones are usually avoided and not even approved because of the side effect profile, such as weight gain, and some even have some carcinoma profile as well. So they per se are not approved for pediatric use. But before saying that, metformin and lifestyle showed a very good response. Again, insulin. So insulin action, of course, when there's insulin deficiency. And one very important part is when do we give insulin? I'll be discussing it. But one of the very important points about insulin is it helps retain that insulin secretion capacity when there's glucotoxicity. So whenever we have high sugar levels, it's better to give insulin rather than wait for anything. The protocol of insulin is whenever we have ketosis. Now, various guidelines may say A1C more than 5, 8.5 or 9. But if you want to just remember any hyperglycemia more than 250, any ketosis, any DK, think insulin, nothing else. We can start any glargine U100 or U300 or deglutec as just now discussed. We can start with 0.3 or even 0.2 and can go up to 0.5 and even higher when we are giving basal bolus or complete insulin therapy. Now, GLP-1 receptor analogues. Of course, there's been a lot of discussion because these drugs have been approved for 10 years and above for type 2 diabetics. The action is, of course, by inducing satiety, increasing effect, and reduce gastric emptying. There's glucagon inhibition as well. Now, liraglutide has been approved, that is 0.6 mg daily. Dulaglutide is also there, which can be given weekly. And liraglutide can be built up from 0.6 to 1.8. There is associated weight loss, and we have ourselves seen GLP-1 analogs showing remarkable weight loss and really helping them with their journey of type 2 diabetes. The main burden of type 2 of this drug is GI side effects, the extreme bloating, the fullness, which makes them lose compliance with the drug. But we must counsel them once this initial phase is over, they will show remarkable results. Now, the options which we have are, of course, the other options are dulaglutide and exenatide. Now, this exenatide is also a GLP agonist. Now, this is also subcutaneous and this is weekly, although this is not in India, but this has been approved for use and we are waiting for its arrival. Semaglutide will be a boon as it is an oral GLP-1 analog. We are also waiting for it and it will be used hopefully in children in further times. Now, avoid same for DPP-4 as well as GLP-1 analogs. Avoid if there's pancreatitis or medullary carcinoma of thyroid. Now, this study about liraglutide in children and adolescents in type 2 showed that it showed remarkable improvement. But again, that's what they're saying, at the cost of increased gastrointestinal adverse effects. So coming to the management of type 2 diabetes. So the main thing about type 2 diabetes is the presentation. About any diabetes is the presentation. So if we have someone who is obese, there is acanthosis, not ketotic, mild diabetes, just sugar, and we are screening the child on just obesity. Look at the A1C. If the A1C is less than 8.5, start metformin. If there's improvement, very good. If there's no improvement, consider a basal insulin or consider GLP-1 analog. If there's presentation is an osmotic, not DKA, mind you, just osmotic with an A1C more than 8.5, consider basal insulin at the onset and metformin later if it comes down. If there's no improvement on starting at that 0.2, 0.3 unit basal insulin, you can go up to 1.5 units. Even if that is not improving, consider basal bolus or GLP-1 analogs. But here comes the main thing, obese child, any child in DKA or HONC, consider basal bolus, stabilize the child first, let it go on for a few weeks, it's no problem. Let the ketosis, acidosis come down, then start metformin. If no improvement, consider GLP-1 analogs. Now, the various complications of type 2 diabetes, as I mentioned, are hypertension, dyslipidemia, nephropathy, retinopathy, neuropathies, fatty liver, polycystic ovary. And again, I would like to stress these come earlier and much sooner and progress much rapidly than type 2 in adults. This trial was done again in the same trial of today, and it showed metformin does show improvement in treatment of these complications and can delay these complications. Now, before I start with the case scenario, I would just like to comment on the cohort we have of type 2 diabetes in our center. We have got around 25 to 30 patients, and we have started them successfully on GLP-1 receptor analogues. And many of them are responding to them. But one main thing is that 4 patients out of them went into remission, but all of them have gone into a relapse. So just to show how progressive this disease is, do not take it lightly. It progresses much faster than any other types of diabetes. So coming to the case scenarios, which I just mentioned before this, the 16-year-old girl with obesity, blood sugar fasting was 146, family history positive, and we started with metformin because of a mild case of type 2 diabetes. After 3 months, there was weight loss. The A1C went to 7.2, but there was vomiting, there was transaminitis. So what should be done here? Metformin was stopped. Insulin was started here, and that led to further improvement. After 6 months, the transaminitis improved, started on metformin. HbA1c also came down to 6.4 off insulin. But then there's fever, vomiting, and loose stool. The child is dehydrated. Now, what should be done? Again, this is 6-day. Stop metformin at all costs. Again, we can start insulin and do progress later. After 2 years, the child is stable, but now there's abdominal pain and gallstone disease. This child is now planned for surgery. Again, this is an indication for stopping metformin, and you start insulin again. The 18-year-old girl with obesity, who was slightly more severe than the previous child, and this child had to be started on a basal insulin and metformin also, and there was a response to metformin. But follow-up after 2 months showed there was improvement. So then after improvement, the basal insulin was tapered and metformin was continued. So this child was controlled on metformin. But after 12 months, what happened is there was poor adherence, there was weight gain, A1C 9.2, SGPT again going towards fatty liver. What would be the plan here? So we have both options. We either increase the dose, we either add basal insulin or we add GLP-1 analogues. A 17-year-old boy with obesity, BMI is 42, acanthosis, there's family history, A1C 14, SGPT 120. There is dyslipidemia. What would be the plan here? Yes. One important thing over here is to think of bariatric surgery. Now, bariatric surgery should be considered if we have any obesity more than 40, BMI more than 40 or 35 plus with complications. So that should be kept in mind. GLP-1 analog would be a very good option over here because it has been shown to decrease obesity very well. We should not. That's the main. That is a good one. These things were started, but over the time, obesity should be considered. So the learning points with this discussion was mostly consider with obese, non-ketotic, and pubertal. Pre-pubertal, do not consider, but very less chance of bringing type 2. If there is guarantee positive, consider autoimmune workup. Metformin, insulin, GLP-1 receptor analogues are the mainstay of treatment, and assess and manage complications accordingly.
I have 2 adolescents with the same family, the family history of type 2, obese with acanthosis, and their insulin on which I added metformin still not controlled. By giving insulin, they gain weight. On metformin alone, things are getting worse. What do I do? I think this is a difficult situation. They would probably need a GLP-1 receptor analog that will help in terms of reducing weight. When you give insulin, weight gain will happen. That's a problem. For patients coming on DK with no GAD, no other antibodies, low C-peptide, no obesity, no acanthosis, what can be the etiology of their type 1 diabetes? This is classified as type 1B diabetes. So when we say type 1A is immune, type 1B is non-immune. There might have been antibodies which are not negative. I would say that way. So don't worry. So in our classification, we say autoimmunity beta cell. If your beta cell is 0, doesn't matter whether immunity is there or not, you have to give insulin for long. So not to worry. So